Hey, good morning, everyone, and welcome to EuroNurse. We meet every Saturday at 9 a.m. Central Time. For those of you joining us from LinkedIn, YouTube, or Facebook, welcome to the show. Be sure to like or subscribe to our channel. And hey, if this is your first time to check us out, be sure to check out our website at euronurse.com. It's the best place to interact with the show, to be involved in it, find out what's coming up. And we got lots of good shows in the future coming up. So be sure to join our EuroNurse group. And it's also the best place to check out our previous episodes. We've now got 43 episodes. Today will be episode 44. So be sure to check out our past episodes anytime you want on demand at the website. If you're interested in subscriptions to help support the show, just check us out there. And hey, this is the way you interact with us, the comment box. No matter how you're watching us, use that comment box to go ahead and put in a chat, a shout out, a question, talk to the audience. The audience can talk to us through that at any time. And speaking of programs, this week we've got our own Andrea Strong, who's going to be presenting this part 2 of OAB. Hopefully you watched part 1 in the on demand. If not, that's why it's up there. Check it out. But she's going to be discussing first line and second line therapies. And at this point, let's go ahead and bring in our experts. Hey, welcome, guys. How's everything going?
Good.
Good morning.
Let's bring up your names here. So for those of you that are not familiar with who I am, first-time joiners, I saw a few new names on the registration. My name is Vic Sinise. I produce and host the show. Been involved in urology for more than 3 decades, pushing almost 4. And really enjoy coming every week to you guys and bringing these great shows. I learn as much as I think you guys probably learn, maybe more. And let's go to John. Go ahead and give your introduction.
Hello, everyone. I'm a private practice urologist in Gilbert, Arizona, who is paying it forward by sharing my experience in the business of medicine to benefit my colleagues. And one of the ways that I'm doing so is by creating the Thriving Urology Practice Facebook group. We're over 2,300 now. US-based urology practice people collaborate to improve all of our practices, and it's all for free. This coming weekend, I'll be speaking at the Texas Urologic Society meeting in Austin, Texas. So if you are a member there, I look forward to seeing you. Back to you, Vic.
Yeah, great. Thanks for that introduction. And now this is our regular scheduled expert and our presenter for today. Andrea, go ahead.
Hi, my name is Andrea Strong. I'm a nurse practitioner in Wisconsin. I've been working in urology for quite a while, since 2010. I've been a nurse for a long time as well. I did inpatient, I did outpatient, a lot of telephone triage, done a little bit of this and a little bit of that. I'm currently the educational director for the Chicago Metro SUNA. I'm certified as a urology nurse practitioner, and I'll be presenting today on first and second line therapies for overactive bladder.
And remember, you SUNA members out there, vote for your upcoming director. She is running for director. So vote early, vote often.
Thanks, Vic.
All righty. We're going to go ahead and bring in our favorite stories, general questions, any concerns people you in the audience might have. Go ahead and put those in. But John, why don't you go ahead and kick us off with a favorite story?
All right. Well, I do a lot of vasectomies. Just in the last couple of years, I performed over 2,200 vasectomies. And this past week, I was performing a vasectomy on a guy, and towards the end of the procedure, it takes me about 5 minutes, I was speaking with him, and I said, "Congratulations, you've completed the procedure. This was hopefully this was nice and easy for you." He was so excited. He removed the laughing gas from his mouth, and he said, "Oh yeah, this was so easy." And so usually I give him this. So I tell him, "Hey, congratulations, you're all done." And he said, "Oh yeah, I've been looking forward to getting that shirt, because a lot of my guys who I play sports with, they usually wear that shirt out to the bars after they played the sport." And he said that it's a great way to let other single ladies know that they've had a procedure and they are clear to date. So I had no idea that this would turn into not just a marketing thing for me, but also a marketing thing for the patients.
Yeah. It's a great idea always to have some way to market yourself to other, potential customers, get the name out there. So that brings me up to my story. So we're coming up actually on our 1-year anniversary. It's going to be in August. And so I've been thinking and running ideas in my head of what to do. So I'm thinking of doing a giveaway because since I've got that great raffle program built into the system. But if you in the audience listening have any suggestions, I'm looking at 2 things. And my wife and I have been talking about what would be a great giveaway. So a pen with the name Euronurse on it. I've got some pretty fancy pens that I've been getting from this company. And so I thought, well, that might be a nice giveaway. Or going with to John's idea, I was thinking of having a Euronurse shirt design. Now, not quite as fancy as this, a t-shirt type thing with Euronurse. So in the comments, if you want to put in what your vote is, what you think you'd rather possibly win on that 1-year anniversary show, a pen or a t-shirt, let me know. So that'll help me decide, because this is episode 44. There's, not that many episodes to go. I'm going to have to get my orders running to get things set. So let me know in the comments, and I'll look into making this special show for the 52nd show. All right. With that, I'm going to switch it over to Andrea and let her go ahead and give her special story. Oh, you're muted. That was her special story, is don't start with the mute.
Thank you. Rookie mistake. So my story is related to overactive bladders and bladder irritants. So my husband and I, a few years ago, were down in Mexico for a wedding. It was absolutely beautiful. And a few days after the wedding, we decided to go to the spa. We were at a nice resort. And after our spa treatments, we went to, it was one of those full service spas. So they had like beautiful waterfalls and steam rooms and hot tubs, all kinds of stuff. So we went to go relax in that area, and they had a few amenities out, some snacks and some drinks. And one of the drinks they had was a sparkling chlorophyll. It was green in color. It was sparkling. They served it in champagne glasses. It didn't have any alcohol, but I thought it was so cute and so fancy. I had 2 or 3 glasses of that, and I am not joking. I had to go pee every 15 minutes for 2 to 3 hours after. It was unbelievable. And I do drink sparkling juices and sparkling waters often. It doesn't tend to irritate my bladder, so I presume it was the chlorophyll aspect. Chlorophyll is supposed to have some health benefits. So I don't know. Apparently, chlorophyll is one of my bladder irritants.
Good segue into first and second line therapies.
Yes.
So, Andrea, I just noticed that for some reason your screen share disappeared. So you're going to have to go back and set that up. While you're doing that, I'm going to go ahead and put some of these comments that just came through here. Collab with Suna and offer a 1-year free membership. Hey, John, that's a good idea. I think I'm going to talk to him about that. So, yeah, any ideas that you have? April likes the shirt idea. I kind of like the shirt myself. Susie, I like Dr. Lynn's idea. All right. So definitely going to talk to the heads of Suna about the free membership. And Rajiv, thanks for that comment. Euronurse t-shirts. So great. And feel free still to put in any of those comments if you want to give me an idea of what you'd like to see for that 52nd episode, and be sure to start planning ahead of time to join us for that. I'm working on what I'm going to come up with for a great episode for the 1-year celebration. So I do see your slides have made their way here. Oops, let's see here. I'm just going to make a couple of things adjusted here. And Andrea, I think it's the perfect time to segue into your presentation.
Thank you. All right, so today we're going to be talking about first and second line therapies for overactive bladder. Dr. Grelnick's already covered the workup and assessment for overactive bladder. I'll talk about first and second line therapies today, and one of my colleagues, Dr. Corey O'Connor, is going to be covering third and fourth line therapies in the future. So just to review, first line therapies are your behavioral...
Andrea, just to interrupt you for 1 second, can you hit the button that says hide next to StreamYard stop sharing? Thanks.
Yep, you're welcome. So first-line therapies are behavioral changes, such as Kegel exercises, changing your diet, monitoring your weight, preventing constipation. These are therapies that can help treat an overactive bladder that have virtually no risks or side effects associated with them. I will find often in my practice that some patients will come to me from other areas and they're already on to second and third line therapies, but they've never been properly educated on first line therapies. So I revisit this at every patient appointment. I think it's really important. Second line therapies are medications. There's currently 2 drug classes used to treat overactive bladder: anticholinergics and beta-3 agonist, and you can actually combine the 2 together. So we'll talk about that a little bit more. Third line therapies, PTNS, which stands for posterior tibial nerve stimulation. We can also give Botox into the bladder. There's also sacral neuromodulation, which is the inner stim. And then fourth line therapies would be surgical things such as bladder augmentation. Quick outline for today, we'll talk briefly about the prevalence. First line, I think that's where we'll spend most of our time today. And then we'll talk about second line therapies. So first, we need to establish exactly what is an overactive bladder. Urinary urgency, that's the most important piece here. Urinary urgency, and this is based on the International Continence Society definition. This can be with or without urinary frequency or nocturia, and it needs to be in the absence of any other identifiable causes. So according to the AUA guidelines, in order to diagnose an overactive bladder, you need 3 things: history and a physical, exam, and a urine analysis. Those 3 things can give you the diagnosis. I tend to get a PVR and a bladder diary as well. But if there's no signs of infection, no microscopic hematuria, and just a reminder on that, any urine that has more than 3 red blood cells per high-powered field requires a microscopic hematuria workup. And again, there can't be any other identifiable diseases that might cause this. For example, if your patient has multiple sclerosis and they have urinary frequency and urinary urgency, it's not an overactive bladder, it's neurogenic lower urinary tract dysfunction. If your patient has Parkinson's disease and they're complaining of urinary frequency and urgency, it's not overactive bladder, it's neurogenic lower urinary tract dysfunction. And then on the right-hand side, you'll see our OAB patient crying because she's going to the bathroom so frequently and urgently, and she's drinking her bladder irritant at the same time. So the prevalence of overactive bladders, I had a hard time finding updated sources on the prevalence, but the Urology Care Foundation does cite about 30 to 40% of the general population. Before we talk about bad bladder behavior, I want to talk about normal bladder behavior. You'd be surprised how many patients come in and say, oh, well, I'm going to the bathroom all the time. You ask more questions and it turns out they're going pee every 4 hours, which is actually considered normal. So first, educate your patients and yourself on what's considered normal. So I'm going to go through some outline here on what's considered normal. You'll see a little bit of variations depending on what your source is on what's normal and what's not. But in general, bladder capacities between 300 to 400 milliliters. That's roughly 1 to 2 cups or 8 to 10 ounces. Normal to go to the bathroom about every 3 to 4 hours, depending on how much you're drinking. If you're drinking 5 liters of water, then you are going to have to go to the bathroom more frequently than every 4 hours. Nocturia, about 1 to 2 times per night. 24-hour urine output is about 1 to 2 liters a day. And then the recommended daily intake is roughly 64 ounces per day. So let's talk a little bit about first-line therapies. Bladder irritants. So these are coffee, tea, caffeine, soda, artificial sugars, anything sparkling or carbonated, citrus fruits such as lemons, limes, oranges, or pineapples, sometimes chocolate, sometimes tomatoes or tomato products like spaghetti sauce or ketchup, And definitely alcohol will irritate the bladder as well. So sometimes just educating patients on these bladder irritants can make a huge difference for them, because people don't realize that coffee is normally going to cause some urinary frequency and urgency. So I'm just curious to know what everyone's favorite bladder irritants are. If you could just put that in the comment box. Vic, if you could read those off. My favorite bladder irritant is coffee, followed very closely by champagne. Any other favorite bladder irritants out there?
Watching the show, we're starting to see some coffees come. Caffeine, coffee.
Yes. Absolutely, especially at this hour of the day. Interestingly, there's some uncommon bladder irritants that can happen as well, such as chlorophyll. I'm curious to know, there's a lot of experienced urology professionals listening today, and I know you all have some very interesting bladder irritants that you've seen in practice. I'd like you to share that in the comments. And then Vic, if you could read that off, that would be great. I can think of one. I just had a patient the other day who found that one specific flavor of a sparkling water was really irritating her bladder. And it was really just that one flavor. It was, I think, papaya or something strange.
I know my daughter had a bad time with chocolate as a child.
Oh.
If we're going on a car trip somewhere and we gave her chocolate or she had chocolate, it was like every restroom you had to stop on the highway.
Oh my goodness.
Right, we are getting some here. Licorice is another one that came up.
Oh, interesting. Okay, so moving on here. Bladder diary. So bladder diary can actually be a treatment for overactive bladders. I have some people who just pay attention to how much they're urinating, how much is coming out, what they're eating, and what they're drinking. And they find that just that alone can help improve things for them. So in my practice, I tend to use a handwritten bladder diary. But there's also a lot of apps out there. I don't commonly use them, but iUFlow is one of them. Vesica, Healthy Bladder Voiding Diary, blad.doctor, UR-app, and then there's one called My Bladder. That's, I think, the SUFU's specific bladder diary. So I would love to hear later in the presentation if anyone's had experience with these apps and what they kind of prefer in their practice. So bladder retraining. This is a method that can help with overactive bladders. Delayed voiding is one of the tactics. I only do this for patients if I know that they are not holding on to lots of urine. For example, I've seen some patients come in with bladder diaries because of urinary urgency, and I find that they actually aren't urinating until their bladder has 700 or 800 milliliters. So, of course, yes, you're going to have a lot of urinary urgency if you're waiting that long to go to the bathroom. So if I have a bladder diary confirming that the patient is voiding in small amounts only, then we talk about doing some delayed voiding. One of the methods that you can do to help with that is called quick flick Kegels or urge suppression technique Kegels. So what I tell patients to do is when you get that strong urge to urinate, pause for a moment, take a deep breath, and do fast Kegels. Squeeze, relax, squeeze, relax, squeeze, relax, squeeze, relax. That will actually send messages through your spine to the brain telling your bladder to relax. And sometimes that urgency to urinate will subside. The idea in my practice, what I tell patients is to just try to wait 10 minutes and then go to the bathroom. If that works out okay, then try to wait another 10 minutes the next week and go to the bathroom. A lot of different tactics and techniques for that delayed voiding for patients, but it can work. Double voiding. This works well for patients who are not fully emptying their bladder. So if you've got a PVR that's slightly elevated, 100, maybe 150 milliliters, you can educate the patient on double voiding. So that's where the patient will urinate, have them wait a minute or two, and then try to urinate again to get the bladder completely empty. Timed urination is another tactic that can help with urinary urgency. I find that this works best for patients who have cognitive issues, Alzheimer's, dementia, any confusion, history of a stroke, especially if they've got some component of functional incontinence. Just a reminder on functional incontinence, these are patients who tend to leak urine on their way to the bathroom just because it takes so long for them to get there. They may be reliant on caregivers to help them ambulate to the bathroom. They may be reliant on pressing the call light and waiting, or a walker or another assistive device. So timed urination can definitely work well in that population of patients. I can think of another population. I've had some younger patients with diagnoses that require them to drink a lot of fluids. And they were sort of waiting too long to go to the bathroom on the bladder diary. You could see that the patient wasn't urinating until the bladder was 700 or 800 milliliters full. And so what we did was just put them on a timed voiding schedule of every 2 hours, set an alarm on their phone. That way they're able to empty their bladder when the volumes are lower. Kegel or Kegel exercises. I don't know if it's Kegels or Kegels, but I'll have some patients correct me one way or the other. These are basically exercises that can help strengthen the muscles and calm the bladder down. It's important that you do a physical exam to make sure that the pelvic floor muscles are not too tight before you teach a patient on how to do Kegels, because if they have a high tone pelvic floor and you're telling them to do exercises to strengthen the pelvic floor, you could actually make it worse. In fact, episode 13 of UroNurse is a great episode from a pelvic floor physical therapist who really does a great deep dive into Kegel or Kegel exercises. I do tend to do exams to make sure that the patients are doing these exercises correctly. If you are working with a patient, if you're working with a female patient, you can do a pelvic exam and then ask them to do a Kegel to make sure they're doing it correctly. You will often find that females will actually bear down or push in a form of a Kegel. So I tell patients your abdomen should not be moving, your buttocks should not be moving, your thighs should not be moving. Everything is internal and no one else should be able to tell that you're doing these exercises. For males, I tend to have the patient do an example of a Kegel or Kegel exercise, and you should see that the penis and the testicles will raise up a little bit, and that indicates that they're doing a correct Kegel exercise. Biofeedback, so these are often using some technology devices, EMG patches, to help the patient isolate those muscles. So that's a little bit about bladder retraining. I just want to mention a few other issues that could be contributing to overactive bladder symptoms. Uterine enlargement. So you can see on the photo here of the female anatomy, the uterus sort of flaps over top of the bladder. That's the natural anatomy. So if you're pregnant, yes, your bladder is going to be smashed a little bit by that aspect of things, and it's going to make you have to go to the bathroom more frequently and more urgently. I've also had patients with a lot of uterine fibroids with uterine enlargement, and you'd actually be able to see sometimes on a cystoscopy that the bladder has some external compression, and you can kind of see that divot, that compression from the inside of the bladder on the cystoscopy. Constipation. This can make overactive bladder symptoms worse. I always tell patients the rectum is right next to the bladder and the bowels are above it. So if they're really full of air or stool, it'll smash the bladder a little bit, and the bladder can feel pressure, but it's not smart enough to know, is that pressure coming from a full bladder with urine or is that external compression? So sometimes correcting that constipation can really help with overactive bladder symptoms. Weight loss. When there's extra weight on top of the bladder, it can compress the bladder some and contribute to these symptoms. So I tell patients it doesn't have to be like tons of weight that they need to lose for the benefit. Even just 5 to 10%, you could see a benefit in these symptoms. All right, so we're going to talk about second-line therapies. These are medications. Anticholinergics are a drug class that have been around for a long time. This is going to be the Detrols, the Ditropan, Enablex, Oxybutynin, Oxytrol patch, Toviaz, Vesicare, Sanctura. These medications do work well. Sometimes they work too well and make it difficult for patients to empty their bladder. So it would be a good idea to have patients back for a post-void residual in 2 to 4 weeks after starting a patient on these medications. They also have some side effects: dry eyes, dry mouth, constipation, sometimes memory issues. And there's some new research indicating that there may be an association between anticholinergics and risk of developing dementia. You can't take these medications if you have narrow angle glaucoma. Narrow angle glaucoma will often present with symptoms of severe eye pain, blurry vision, halos, headaches. Usually the eye will be bloodshot, so it's contraindicated in narrow angle glaucoma. You also want to use anticholinergics with extreme caution in patients that have any history of urinary retention. We've all seen those patients come in for a fill-in void or a voiding trial after having a catheter inserted for urinary retention, and you see that they're on oxybutynin, which is probably contributing to that urinary retention. So be very cautious in those patients. Also, anyone who has gastroparesis. So sometimes, for example, with diabetes, the nerves can become damaged and it causes the loss of the bowels to be able to do the peristalsis movement. You do want to use anticholinergics in caution with those patients because it can really cause more significant problems with constipation. We could talk a long time about anticholinergics, also known as antimuscarinics, but I'm going to move on here to the beta-3 agonists. This is another class of drugs, and they'll also calm the bladder so the patient's not going as urgently or as frequently. There's currently 2 beta-3 agonists on the market. One is myrbetriq, also known as mirabegron. The other is Gemtesa, also known as virbegron. So myrbetriq side effects commonly can be a headache, sometimes a stuffy nose or upper respiratory infection. Also indicated that it could increase risk of hypertension, although I have not seen that in my practice. There's a risk of causing urinary retention, although the risk of urinary retention is not as great with beta-3 agonists as it is with anticholinergics. It can also contribute to urinary tract infections. Gemtesa, this is also known as virbegron, similar side effects, can cause a headache, stuffy nose, upper respiratory infections, can cause nausea. Gemtesa does not have a risk of increasing blood pressure. So that's one of the benefits. If your patient's concerned about that, you could order Gemtesa instead. Can still cause some urinary retention and some issues with urinary tract infections as well. You can actually do combination therapy for these patients. So if you find that either the anticholinergic or the beta-3 agonist are working well, but not well enough on their own, you can combine medications. So you can give, let's say, Vesicare with myrbetriq. You could give oxybutynin with Gemtesa and use these combinations. And the research does show that patients can have a greater improvement in their symptoms. So just to review here, today we talked about first-line therapies and second-line therapies. In the future, one of my colleagues will cover third and fourth-line therapies. So I want to thank everyone for being here today for this presentation, and here are my references.
And that was great presentation.
Thank you.
So let's see here. This is the time, folks, that you can go ahead and put any questions that you might have. Feel free to ask. I've got a couple myself that I'm going to ask you here. So one of your slides had uterine enlargement as a cause for overactive bladder. And yeah. I've done a lot of urodynamic studies, so that's where my knowledge is coming from. One of the things I noticed is BPH, the same thing, that enlarged large prostate, causing the same thing. You do a study, they've got obstruction, but they've also got overactive bladder caused from that. Yeah. And a lot of times, especially I think like the TERPs, where they relieve that volume somewhat, I've seen better responses. So what are your thoughts on?
Absolutely. Yeah. Urinary urgency and frequency can be caused by bladder outlet obstruction as well. And sometimes it can be hard to differentiate. Is this just pure overactive bladder, or is there an outlet obstruction piece involved? You can certainly do urodynamics, but one thing that you can do that's easy and low risk in the clinic is a uroflow and a bladder diary. And that can help guide your treatment decisions.
Yeah, exactly. For the audience out there, bladder diaries, do you guys use them? Don't you use them? And I've got a little bit of a reason why I'm asking the question. So besides doing Euronurse, being around for as long as I have many, or not many companies, but some companies reaching out to me as a consultant. And I just recently, this past week, was asked by a company to consult on a project they were doing. And they're looking at voiding diaries that are automated. Now, I know you mentioned several software things. Their particular one they were showing is one that has a device that you urinate into, and it measures the amount of urine. So the patient doesn't have to try to figure it out. It's done electronically.
Oh,
and
nice.
My question to the audience out there is, do you think that this would be something useful? Number one, do you do 3-day or any number of voiding diaries days? I usually do a 3-day, but are you doing it? Is it something that's commonly done? And then lastly, what would your price point be? And I'll throw this out to the panelists right now, and then you guys can put this up in the comments. I'd love to hear what your thoughts are. Would I spend, because it's not covered by Medicare or insurances, would you spend $100 for it, $50 for it? What you think would be a good point? Just because it made me curious after I was doing this consulting work, what other folks are doing and what their thoughts are. But yeah, go ahead. Panelists, you have a thought on voiding diaries? Take it away, John. I'll throw it to you.
It's a very good way, as Andrea presented very nicely. It's a good first line evaluation, and it's always a good idea to get a good history. We were taught in medical school that if you get a good history, the patient gives you the diagnosis about 90% of the time. So it sounds like the product that you're considering is similar to IU Flow, which I think has a device that the patient voids into and then measures the volume and how fast it's coming out. So as far as the value goes,
as far as cost goes, would you?
Yeah, as far as the value goes, that's gonna be a tough one. It's whatever the market will bear.
Yeah.
To the patient who is extremely symptomatic, they're willing probably to pay a certain amount, but how much is that amount? That is the hard thing. I think for the company that you're consulting with, they're just going to have to come up with the price point and go with that, because right now with inflation, that price point may be different in the future when the inflation is down a little bit.
Exactly.
And also with a lot of people being strapped for cash, with a lot of car loan repos rising and interest rates rising, the unprecedented amount of credit card debt that is happening right now. So that price point may vary depending on which financial situation people is in.
Yeah, no, good point. Andrea, any thoughts on cost? Would it be, do you do a voiding diary all the time? What's your thoughts?
Yeah, I do try to do a voiding diary all the time, but some patients will be very honest and just say, you know what, I don't think I can do this bladder diary because I'm too busy, or I know I'll forget. We have patients who also have issues with vision. If you give a patient a urinal, the actual numbers on that urinal are very small, very hard to read. It's almost like Braille. There's no color differentiation in the actual number. So it can certainly be a challenge. And some people work, 6 days a week. And so saying, doing a bladder diary on a weekend is not really feasible for everyone. 3 days would be nice to get a bladder diary. I'm lucky if I get 2 days worth, and some patients can only do 1 day's worth. But it can be really revealing also in finding if there's nocturnal polyuria, if the patient's making more than 35% of their urine at night. That can tip you off to, okay, do they have obstructive sleep apnea? Do they have heart failure? diabetes? Is there something else going on that's causing that nocturnal polyuria? Or you may just find plain old polyuria. Patients who are drinking large amounts of water, I often see that for patients that are working on weight loss, will be drinking very large, like 5 liters of water a day. And that's just causing frequent urgent urination. That's not a pathology at all. It's just normal based on how much they're drinking. As far as price point, I really can't comment on that because I don't know all of I'd have to compare what are the similar products on the market and what's going on. But I could see that product might be beneficial for some of my patients who have difficulty with vision, because the system would measure it for them.
Yeah, that's some good points. Just a tip off. So when I was thinking about this cost, I said, I have a son-in-law who works for the company Crumble. They make these big cookies, but they're $6 a cookie. And I'm thinking, who's going to pay he tells me he's going to go work for this company. He was looking at the job. And I said, who's going to pay $6 for a cookie? Well, let me tell you, a lot of people pay $6 for a cookie. Thankfully for him. But, so I don't know, always you wonder what the market will bear is always kind of the concern. And I think the one point that you made that I really agree on is the compliance goes way up. I think if it's the simpler it is, the more compliance you're going to have. And then second thing is accuracy. So again, even people with good vision, it's, unless you're trained to look at these, read these type of devices, you're guessing things. Even when I'm trying to sometimes to bake, I get the cup up there to measure and it's close to what it should be.
Yeah, sometimes it's hard to tell where the number is indicating. Is it this line or is it that line? For those of us who are somewhat used to look at graduated cylinders. And Andrea said something really important, which is to, again, history. Sleep apnea. You see all your patients walk into the clinic, most of them, because about 70% of Americans are either overweight or obese, that obesity is associated with more snoring, and that snoring often leads to sleep apnea. And it's surprising to me when I ask these patients, have you had a sleep study? And they tell me they never had a sleep study. When you look at them, they just look like someone who has sleep apnea. And sleep apnea is associated with urinary frequency, nocturia, also erectile dysfunction. A lot of people don't realize that. So I counsel patients on obesity because it involves not just their other diabetic and hypertension issues, but also overactive bladder issues and also erectile dysfunction. And when you talk to a guy about erectile dysfunction, their antennas go up, and they set up like, oh, what are you talking about? Erectile dysfunction. And something that I don't think was mentioned is that when I was just starting out, I was evaluating this guy with, I thought, wow, horrible urinary issues. It was someone who works in the church. And at about 4 months after starting him on tamsulosin, he said, oh, doc, I passed a stone and my symptoms immediately relieved, were all gone. Well, fortunately, tamsulosin was being used on label for BPH and off label for medical expulsive therapy. So a stone in the distal ureter at the renal vesicle junction can also give a person some of these urinary frequency urgency symptoms. Lastly, for patients who have BPH, I often do a procedure like a TURP. Before that surgery, I will tell him that frequency, that urgency, and then getting up at night, the irritated voiding symptoms may not resolve right away or may take a long time to go away. It'll improve, but it may take a long time to go away. So BPH and also post-op irritated voiding symptoms may persist and also may start, even though you didn't have a significant amount prior to surgery.
That's kind of that first line therapy, behavioral. People just get used to getting up every, so often at night, and it's hard to break those habits.
And that's exactly right. I tell these guys before surgery that after surgery, you're going to have to retrain your bladder and also retrain your mind often it's behavioral. It's a habit.
Yeah.
So you have to break out of that habit after surgery.
Yeah.
Yep.
So,
I'll often tell my patients that, the bladder is a muscle and it has memory. If you've been peeing every 30 minutes for 5 years, the bladder is going to want to continue to do that. But there's definitely success with bladder retraining. The research does show that bladder retraining is more effective when combined with an overactive bladder medication.
And you also mentioned using combination therapy. So don't forget that you can use so for some people an alpha blocker and an anticholinergic, which in the past we think, oh, that's just blasphemous, but it does work. Or
Yeah.
combination of a beta-3 agonist and an anticholinergic.
Yep, absolutely. I think it's something that we often overlook, but it's very effective. And if we can prevent the patient from having to move down the line to third line therapies, then that may be beneficial for them as far as risks and costs. One thing that I didn't talk about in the presentation was the fact that you don't have to I think everyone should get education on first line therapies, absolutely. But you don't have to go in that exact order. If I just had a patient the other day who said, I'm not absolutely taking any medications. They really wanted to avoid polypharmacy. So we went right to PTNS because we had the bladder diary to support coverage for that. So it doesn't have to go in that exact order.
yeah, good point. So we do have a comment coming in here. Raj said, imipramine is also used at our facility. Any thoughts on imipramine?
Yes, I have seen this medication used for some patients. It can help kind of relax the bladder. We usually use it more in neurogenic bladder patients, but I don't have a ton of experience with using it myself.
Good. Susie said she's using the voiding diary. Ryan says he uses them. And everybody else doesn't want to comment. So anyway, if you do, feel free to add that into the comments, whether you're using them. And I'm kind of interested in that price point, what people think would be a good price point. I will tip my hand. So I did tell them I thought it would have to come in at under $100. And the other units that are out, so they were looking at, they knew there's other products out there. This particular one had a more attractive price point. And I think that's what they're looking at. If they could get the right price point, would it be something useful in investing in? So we'll see. Time will tell, right?
Yeah.
Let's see. I had a couple.
If it's easier, if it's cheaper, if it's better, then obviously market adoption is going to be greater.
And always, if insurance were to cover it, then the adoption goes way up because everybody's willing to let the insurance company bear the burden. But again, people are hooked on convenience. I think now, I'm kind of amazed. We talk about the economy and the effect that it's had, but then I was reading today's paper, and I guess Taylor Swift was having a big concert in our area in Chicago, and it was like all these fans that are paying all this money to go and see her, and then all the people that were paying money to be just outside the facility just to be part of the aura or something. So, people will pay. That's the bottom line. If you got a product that's good and the people appreciate it, it doesn't seem like money's always the object, but that's just my 2 cents worth.
No, consumers need to see the value of whatever company is offering. And if you have just think about Amazon. When they increased the price of their Prime membership, how many of us actually thought it's not worth my while? I'm going to cancel because they upped the price.
Yeah.
I didn't even think twice. I continued it.
You're right. And convenience. I mean, that's I'm as guilty as the next person for being lazy. I don't take a lot of prescriptions, but that even at the 90 days, going to the Walgreens, sitting in the line at the drive-thru to get my drugs drove me crazy. So once I switched over to Medicare and had to do something that route, I just said, I'm going mail order. It's just easier.
Oh,
let them
definitely
send it in the mail.
Yeah. Humans have two guiding principles. Number one, we want to survive. And number two, we want to do that in the easiest way possible, meaning we're all lazy.
Yep, absolutely.
We want whatever the destination that we want to get to, we want to do it in the easiest ways possible. And Jeff Bezos has brilliantly done that with Amazon.com.
Yes. Yeah, I agree. So one of my other thoughts is, when talking about behavioral therapy, I've had, when you can get a good motivated patient, I think it's really successful. That's the whole thing. Get a good motivated American, somebody who's going to be willing to put the time, effort to do Kegel exercises. Everybody wants a pill to fix everything. And as Andrea mentioned, polypharmacy is getting huge. Sometimes I take medical history and I start writing down all these, or now typing them in, all these medications. It's just incredible the number of medicines they take. And I don't know what other people's feelings are, but somebody had once told me anybody who's on more than 5 drugs is probably on too many. So I'm sure depending on what your situation is, but you do see it. I mean, even in OAB, they're on, like you said, an alpha, tamsulosin. They're on an anticholinergic. They're on a beta agonist, and that's 3 drugs just to treat one problem. And if you're paying for all that, that's a lot of cashola, especially first line therapy. The non-generics.
Yeah, absolutely. There's certainly concerns with polypharmacy. And you're right. If you do have the right motivated patient who can do and willing to do the first line therapies, they can cure themselves. I've had a few patients do it. It's usually a nurse.
Yes, I agree. I'll try anything that's behavioral first.
Yeah.
I'm adverse to taking medicines.
Yeah.
Put it on my giveaway. I don't know. I think I lost that one. Thank you, Andrea. I had not thought of the gastroparesis and decreased colon peristalsis causing this as well. Of course, you're going to learn more here at Euronurse, right? Charlene Valmer said, cared for many diabetics with this issue. And I think sometimes that I mentioned in Who Needs Urodynamics. And, sometimes start with the simplest thing, a UA. UA can tell you sugar in the urine, might diagnose that diabetic who didn't know they had diabetes. Of course, we said urinary tract infections, all things that can cause the same exact symptoms as overactive bladder.
Mm-hmm. Absolutely.
And you mentioned, go ahead.
Oh, I was just going to mention, speaking of cost, I know we've all had the prior authorizations for the beta-3 agonists and the cost of that. And unfortunately, sometimes I'm left with not a lot of options because of the cost of the beta-3 agonists. And we end up having to do the anticholinergics. Now, the AUA guidelines do mention if there is an immediate release versus an extended release version of an anticholinergic, you should go with the extended release version because it's less likely to cause dry mouth for patients. And that dry mouth can be severe. I've had some patients, even young patients, who've gotten a bunch of cavities, dental cavities from the dry mouth from anticholinergics.
That's a good point.
Yeah.
I mean, back in the day, oxybutynin was the only thing available, and wonderful drug. I mean, as far as the relief went, it was perfect. Trying to get patients to tolerate it, no, that dry mouth drove people crazy. And we did everything from, we were making our own delayed. I would have them break it in half, take it every 3 to 4 hours to delay the amount getting in. And sometimes it worked. You could get it to the point where patients tolerated it, but
yeah. I've definitely had some patients, old 80s, 90s, who'd been on oxybutynin forever, many years. So at that point, I talked to them about switching to a different medication with a safer profile for their age. You'll also see when you're giving extended release medications, if you're a nurse in the clinic and you're doing some telephone triage and some education, remember to tell these patients if it's an extended release version, do not crush, do not chew. You need to swallow the pill whole. There's been a few times that I've heard some patients say, that extended release oxybutynin works, but I have to chew it in order for it to work.
It's a good point. And sometimes we do forget about how people will do things when they get home.
Mm-hmm.
And also you mentioned the narrow angle glaucoma. If it's treated, then the patient can get on an anticholinergic in a very careful fashion. So getting a good history, you just can't skip that part.
Yeah. So that's I think our number one thing to drive home is good history is going to get you far. And unfortunately, I think that, in today's society, with the number of patients they want, pump through your office, the good history part is not always the number one priority for the practitioners out there. So
And
the really
sometimes
good
patients
ones
forget. Yeah, and sometimes the patients forget. They can't recall what medications were tried.
Oh yeah, absolutely. And what medications they're even taking at that point. I still to this day, it's just something ingrained in myself. Whenever I see a patient, I still run through their med list with them, because I'll go, I don't take that one anymore, because this EMR will pull up things from their pharmacies, and it could be drugs that they're no longer taking. So, it's always good to review the medications with the patient every time you see them. You're just going to get better information, so you're not putting drugs that interact with each other when you're thinking of your treatment options. And the same thing with allergies. Patients will say they're allergic to something. You go, well, what kind of reaction did you have? Well, it just bothered my stomach. Well, that's not really necessarily an allergy that you couldn't take the medicine if we needed to. There's maybe another medicine that would work better. So histories, folks, take histories.
Yep.
Audience, we're open to questions. Again, you guys drive the show. If you have any questions or thoughts of your own use, what you've come up with. Didn't see too many price points coming out there. If you want to share what you think would be a good price point for the this device that I was consulting on, I'd love to hear what your thoughts are. Again, I said mine was.
And for my APPs who are performing cystoscopies, or any practitioner who's watching this, don't be shy to perform cystoscopies. For BPH, AUA guidelines are recommending that you perform some sort of evaluation, including cystoscopy and also imaging the prostate. But cystoscopy can give you so much good information. I saw a gentleman this week, as a matter of fact, 82 years old, history of prostate cancer, had radiation, and he was complaining of a sudden onset of severe urinary difficulties. So I figured I'm going to look inside the bladder. As soon as I got to the prostatic urethra, there was a stone stuck in the prostatic urethra. So that would explain why he all of a sudden had trouble urinating, like just came out all of a sudden for someone who's 82, who had radiation, prostate cancer is under control, and it was a small stone. And then he said, oh yeah, I have a history of stones. And one of the stones passed into the bladder, but then got to the prostatic urethra. It was a little stuck because of radiation made the prostate not as pliable, I guess, for him. So the stone was stuck, and schedule him for surgery. Should be able to take care of him. Another patient recently, it was a 21-year-old who came in with painless gross hematuria and some urinary urgency. Looked in the bladder, saw a mass in the bladder. So cystoscopy is the key.
Yeah. I don't know if you mentioned that, Andrea, but bladder cancer can also be a cause of overactive bladder.
Yep, absolutely. Usually you'll have microscopic or gross hematuria with the bladder cancer, but not 100% of the time. So if there is any history for high risk for GU cancers, such as smoking is the biggest one, male patients are more likely to have a GU carcinoma. Any history of, I always ask about breast cancer, because Cytoxan, also known as cyclophosphamide, can increase risk of bladder cancer. If they worked in manufacturing with diesel fuels, dyes, leathers, I think there's a few other occupations out there that put patients at a high risk for bladder cancer. So if there's any of that, even if they don't have microscopic hematuria, you could definitely get a cystoscopy on them to make sure you're not missing anything.
Yeah, I agree. And I think, today, in the old days, you had to be kind of a braver patient to go through cystoscopy with the rigid scopes. But nowadays with these flex scopes, especially some of the new ones that we've got, they're so skinny. I mean, they're really not a bad procedure. Most patients will say, yeah, it wasn't as bad as I thought it was going to be. But I can tell you, in my career, we had one old-time urologist, and it used to drive me nuts, because he would, these young guys, people would be coming in and with frequent urination, and we'd run kind of the basic spectrum, and he'd say, I want to do a cysto on that guy. I'm like, really? You just want to keep me here longer, right? And sure enough, he'd find a bladder tumor. So I don't know if it's just he did so many that he could catch, enough by just the quantity. But I think he just had that suspicion. And it turned out this particular guy I think it was in his 40s. He worked in a janitorial service, and some chemical that he was using was found out to have, I think, benzene in it or something that caused it. So good.
I had an interesting situation where I prescribed a beta-3 agonist. It was effective, and now the patient wants to take it. Often, as you probably encountered, insurance has no coverage or very little coverage. So it's going to be $300 or $400 a month. And he found an online source from one of these Canadian pharmacies. And so now I had a Canadian pharmacy fax something to my office asking me to prescribe to that pharmacy in Canada. So I said, no, I'm not going to do that, but I'm happy to print out a prescription for the patient to take with him or her, and then he or she can do whatever they want with that prescription. But I don't think prescribing to a foreign pharmacy is a good idea for a practitioner. Just something that came up this week.
Yeah.
Sure. That's interesting. I haven't had that issue come up, but I do know Gemtesa, if you go to gemtesa.com or mirabetric.com, they do have some coupons available for patients.
I highly, highly, highly encourage all my patients to use goodrx.com and no financial interest. So ED is a problem that is prominent for a lot of my male patients. And often they'll have one of the big, like CVS or Walgreens, one of the big box pharmacies listed as their pharmacy. And I will go through that GoodRx with them. And the difference in price it's criminal. $6 for a 30-day supply versus $384 for that same thing, depending on where you're getting that medication filled. So number one, it could mean compliance or actually getting the medication. And number two, it's just you're saving so much money by knowing the fact that there are options out there.
Yeah.
Good point. I've given patients those cards that they give you for the GoodRx. They can look into it, but actually like I said, I went on Medicare not too long ago. And so the thing I've been doing is comparing prices of drugs. And the one I also found that's a good deal is this thing from Mark Cuban, the guy from that show, the Get Rich Quick or whatever the thing is. But anyway, he's got his own pharmacy. Yeah, Shark Tank. Yeah, he's got his own pharmacy that he put out just with that in mind, that to make drug costs less. They've got like a set fee that they add to the cost of a drug. And I was amazed. I compared it with what I was currently paying, and it's like far cheaper than them. So
wow.
I guess it pays to shop, right?
Yep.
Well, this is great. I don't see any comments coming in that I missed here. Again, Andrea, that was a great presentation. I can't wait till we get 3 in the box. So talk to your speaker and let me know when that'll be, and we'll add that to the list. I do want to thank everybody for showing up and coming to today's program. Let me just turn this floating comment box off here. Well, I guess I can't. I do want to make a announcement for next week's Tune In. Next week, we're going to have Brian Mojica joining us. Brian Mojica is a RN who discovered or created this product called Cathware. And it's a solution for all these bags and catheters hanging around that patients have hanging off of their legs. So definitely one you want to check out. If you haven't had enough of us, you can always go to the after party by going to euronurse.com and just clicking that button. It'll instantly transport you over to the after party. And I want to just go ahead one last time and thank my panelists for joining us as always and supporting the program. And thank you for coming to the program. And we'll see some of you at the after party. Hopefully the rest of you are going to go out and enjoy this really nice day. Goodbye, everyone.